You're watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. This is a special edition, and it's kind of breaking news we have here today. My first guest is a neurosurgeon, spine surgeon, well-known all over the world, and we're talking about the end of back pain, possibly, and neck pain. It may or may not be an overstatement to say that, but with us we have an expert on the topic. We've had him on the program before. I've also had him on the Randy Alvarez podcast for a long version. Very interesting. And this is a real interview. I'm just asking the questions. I'm not endorsing him today, but I think, look, if you've got back pain, neck pain, you've got to hear what he has to say. And especially if you've been told you need a fusion surgery, because there's apparently more than 500,000 or even 1 million of these surgeries being done with opening up your back, huge downtime, huge recovery, and now with small incisions, not tearing apart the muscles or the tissues, he's able to do it, in some cases, in about a half an hour. So with us we have Dr. Hamid Abbasi. Dr. Abbasi, welcome to the program. Welcome back.
Always a pleasure to be here in beautiful Carlsbad, Randy.
Now, you have your cell phone on the desk. We may get a surprise call, because I said, well, what are the people? Because what takes other guys 7 hours to do, let's say a fusion surgery, you're doing in 45 minutes or under 30 minutes, and even complex scoliosis surgeries. And I said, I mean, these people that work in the ORs, the operating rooms, they must be surprised. You said, I'm going to have a guy call. You ask him yourself.
Yeah, it's a team, truly a teamwork. Now, no captain in any ship can navigate all by himself. You have to put a good team together, and in places we have been, we have that good teams together, and that team helps me to deliver this kind of care at the level that is unheard of for the spine surgery. And the result are patients that benefit from the surgery without going through the downside of the surgery, which is like being intubated for 5, 6, 7 hours. And that teamwork is extremely important. But so I called my OR today, and I said the person who is usually scrubbing with me, and he's a very competent person.
Now the scrub tech, just so
scrub tech, yeah.
So these are not medical doctors, but these are the people. What do they do? What's their role? Because we've all seen the medical shows in surgery.
Yeah.
What's a scrub tech?
Well, he's like a first mate on a ship. He truly runs the show where the surgeon is concentrating and performing the surgery. He needs lots of help, instrument. The scrub tech put the right instrument together in an order that for us to perform the surgery properly.
And the reason I want to talk to him, because you said because there's two, we're talking about fusion surgery today, right? It's a new type of fusion surgery. There are only 30 guys, as of today's date.
Around, yes.
Around 30 in the world. Is that fair to say? In the
world?
Yeah,
it is fair to say.
That are able to do it this way.
Yeah.
And you said that this guy that may call in, that he witnesses other 6, 7 hour surgeries.
Yes.
And then he sees yours for the first time. And what do they say? Like, they go, what?
He says that's his favorite kind of surgery. He understands that this is a highly specialized kind of surgery.
No, but when he first saw your surgery, under 40 minutes or so, as opposed to 7 hours.
Well, he was truly speechless, I believe, because he didn't tell me anything the first. But now that we grow more like friends, he tells me that his favorite surgery, and he doesn't want to be in any other kind of spine surgery. But I think it takes a little to sit in that the surgery, that the way we do it, what it really does to the patient, and all the blood that you don't lose, all the time you don't have to cook the tissue to stop the bleeding. And he understands that the elegance of the surgery itself, there's a beauty of doing things simple and efficient. And that is where we are. We do it very efficiently.
So people know what we're talking about. Okay, so spinal fusion surgery, right? Lots of hardware, you fuse the spine. And just correct me if I'm wrong. So people know exactly what we're talking about. Typical surgery, you got to cut them open, cut open hundreds of muscles, 100 plus muscles, that never get attached again, like the girdle that holds your whole body together. You cut those muscles just so you can have access, so the surgeon could see and place the hardware and fuse a spine. And it takes 7 hours because you've got to meticulously, or in a sloppy way, you've got to detach all these muscles, then you've got to put them all back together. You have to control bleeding, as you say.
Yeah.
So it takes like 7 hours. Very risky surgery. In fact, if you're like 60, 70 pounds overweight, you can't even get the surgery. Then there's another way to do it.
Yeah.
And which is the way you're doing it.
You know, I couldn't describe it better. In a regular surgery, you know, anatomically, we call them paraspinal muscle. We give them one name, or we call them multifidus muscle. We love giving them based on their function names, but in truth, each of those muscles, they are hundreds of individual muscles.
They have a function.
They connect to different areas, different bone area, and they have a different function. We put a knife down and cut them and separate them from their point of origin, like no different than if, imagine the orthopedic surgeon would open your shoulder, but cut all the muscles. But that is a part of that. We have been doing it for a long time, but something that we don't say often. In a spine surgery, we do not reattach a single muscle back.
You don't. So these people...
No. They float, and eventually they turn into scar and die.
Okay.
This, even though we give them few names, in reality, as you said, there are hundreds of individual muscles that each have their function. There is a reason for them to be there. We render them useless.
So when you do it today, right? You're going in through what, 6, 8 holes? How many little holes?
Well, depending on how many levels we do the surgery, and that's one of the things that I tell my patient, that it's not about how many holes we use. It's about what we achieve and what happens afterwards.
Like 6 or 8? Is that what we're looking at?
If we do it like I just did multiple of these kind of complex surgeries where we did 3-level fusion. For 3-level fusion, I use usually one small incision to get to the bad disc, but then each screw individually has its own hole, so 8 holes for the screws to put the screws in place to stabilize. But the idea is, and I showed you a picture of that after the surgery, once we are done, and once we take our devices out, because we don't cut the muscle, we just dilate them and they fall back. Practically that area is scarless. There is no scarring or damaging to the tissue. Once, one of the ways I have been able to really impress my colleagues is actually when I bring them to our cadaver labs. Once we do the surgery, we take the tissue layer by layer off on our porcine lab, which is a pig model, or our cadaver lab. We truly take them, the layer by layer, we take the tissue off and we show them what structure did we go through to get the job done. It is hard to see even what is the path of the instrument we take, because once they fall back, they peel themselves very beautifully. And in that area, people heal scarless. Inside, the muscles just turn back to their function away.
So I guess there's one way to access the spine for the fusion, to cut everything out of the way, make room for it.
Fillet patient open.
Fillet them open, as you say.
Yes.
Or to go in, I guess, are you doing it under fluoroscopy or some sort of?
Yes.
Okay.
Yes.
To go in, like using some sort of tools, right?
Yes, very specialized tools.
Specialized tools. To go in and actually just kind of push things out of the way instead of cutting them out of the way. Is that kind of what's going on?
You just described it. What I do.
Well, you taught me a little bit about it. I want to make sure that I understand it. So you have a way to just kind of push things out of the way.
Yes.
Get done, get in and get out, and that's it.
It's about instrumentation. It's about very specialized instrument that enable you what would be impossible even 10 years ago. It's about no different than the watch you have in your hand. It's magic what that watch does. But all what it is an instrument that designed very specifically at highest level to do certain thing for you. Like you just told me that measures the oxygen level in your blood. Yeah, the newest Apple Watch, yeah. That would have been the device that we had 10 years ago to do that, would have been almost filling this table.
Yeah.
And now it is on your wrist. So what we are trying to do to take a complex task and make it easier based on what the instrument provide to us. Like You drive your automatic car, and you don't think about gearing, changing the gear, and paying attention to at what speed. I used to do that. Have to pay attention that at the right speed.
The clutch, the stick shift. Now most people drive automatics.
We don't do that anymore because the machine, the instrument, took care of that for us, so we can concentrate on the road. And this is what we have been doing with very specialized instruments. Make them so specialized, so much more efficient that
it's like automatic.
Like we make it automatic. So making it automatic, it reflects in our efficiency to be able to do this kind of surgeries.
Okay. Now we should mention how many spine fusion surgeries are done a year? Approximately.
In the United States, more than 1 million spine surgeries are done a year. Half of them, more than 500,000 of them, are actually spinal fusions.
So 500,000 spinal surgeries every year, okay? Yes. Of those, in your opinion, and those are all done open, 7 hours at the table, losing a half a gallon of blood, complications, deaths, things like that, how many of those do you think could have been done this new minimally invasive way?
Depending on the level of the training of a surgeon. I mean, when I started that, I started with doing only 20% of my surgeries this way because my level of experience wasn't adequate enough. Now I do more than 95% of my spinal fusions with this technique because as the time goes on, my repertoire of my skills and knowledge that I can draw on has grown to a point that I can do scoliosis with the significant side bending of the spine or things that are more complex this way. So it's all depending on the level of your expertise.
I told you on my podcast that I interviewed a doctor, another spine surgeon that knows you, called you a mad genius, but he also said you were the fastest in the world at this procedure. And I tried to put you on the spot in my green room. I said, are you the fastest in the world? I call it efficient. I said, but are you faster than anybody else doing this? Well, I call it efficient. But the truth is you are faster than anybody else right now doing this. I mean, your record right now is what, about 36 minutes?
Well, actually, for one level, we don't officially keep record.
Okay.
Though I have been told, no, I don't.
Okay.
We have a database. We gather all of our data. But this is the truth that we know everything about this. This is why we are good at. We keep track. And we keep track to not only the time spent on the surgery, blood loss, everything to the finest, the minute details of the surgery. We keep track, we go analyze it, and we get better at that. We have done this surgery in 22 minutes.
Wow.
Now, this is something on the side that I just got aware of that the staff in the OR actually keep bet about how fast we are going to be in the surgery. What I tell my patient is not about being fast, it's about getting the job done. And that job, for me, I say my patient and my staff, I don't perform surgery. Surgery performs me. Because surgery for me is a time machine. We get in so concentrated, we get in to the zone. Once we get everything is in place, we have a good team, everything is in the right place. I start the surgery, and then all of a sudden surgery is done. And but I have been told jokingly that staff keep a bet on how fast we are going to be that day.
Now, so like there's interventional pain management physicians. I've even had a spine surgeon on the show that said, I refuse to fuse. He will not do fusion surgery. And you told me, I bet it's because he knows the harm it does to the patient. Traditional fusion surgery, you're cutting open all these muscles. They're never reattached. And it's only like a patchwork. I don't want to put words in your mouth.
Yeah.
But traditional spinal fusion surgery is kind of a last resort patchwork. Could you elaborate on that?
More than half of the time when we do traditional spine surgery, we are just doing damage control. Obviously, for us to get where the problem is, we have to physically get there in an open old-fashioned way. We talked about that. You feel the patient open. Now you cut the muscle, a live tissue. What does it do? It bleeds. We use fancy words like cauterization or bipolar coagulation and so on. But in truth, we cook the live tissue. We render them dead to stop the bleeding. And more than half of the time in a regular spine surgery, on the way of getting to where you need to be, you are damaging the tissue, you stop the bleeding, and then move forward. You damage more tissue and stop more bleeding.
In traditional fusion surgery, the part I don't understand, we're kind of short on time, but they go in through the obliques, or they go in through the stomach sometimes?
There are multiple...
And the back, so they're going through two areas?
There are multiple ways of going there, but it's still more than 75-80% of the surgeries are performed from the back, where we fillet you open.
You have a picture. Let's go to that picture. I'm looking, what am I looking at here?
Yeah, you're looking at the on one side traditional spine surgery where there is a midline incision, meaning in the middle the skin is open, all the muscles are filleted actually open, and you're looking at the structure of the spine itself. And on the other side, we are able to see some screws that are poking through the skin. These screws are not cutting the muscle, they are actually dilating the muscles, and they are going inside of the spine. Practically once the top part of that screw comes off, the muscles retract, they are back where they are, and that area is scarless. And
so look, the only reason why people would want to get spine surgery or a fusion surgery is because they're in a lot of pain, right? How do you stack up pain-wise? Do you think you also, not only is it done quicker, safer, low downtime, et cetera, they can in some cases walk that same day. What's the success rate? Would you say it's even better?
Yeah. Well, if the success in medicine is not accumulated in one number.
Okay.
We have a scientific way of measuring the success in the spine. We call it Oswest 3 for the lower back. We call it neck disability index for the cervical or neck spine. But more or less, that is, I think, one of the things we do. We gather those data. We don't do just a dozen.
So to answer the question, though, is it better results?
It's peer-reviewed, published data that's out there.
Better results.
That we have better result around the time of the surgery. We have very, very good result toward in the long run. But while the patients are getting from the short to the run, they don't have the complication of the open old-fashioned surgery. So not only we achieve better results, we achieve them sooner and safer.
All right, now let's talk about the pain patient for just a moment. It's very interesting, your take on it. And I even said, how did you develop this empathy? Because you come from a family of pain and you've been in pain before. But you say that unknowingly, these spine surgeons, because they're doing the surgery, they don't know what their life is at home, what the rest of their life is going to be like, but unknowingly kind of ruining their lives. I think you said close to what I'm just saying now. So the typical fusion surgery can ruin people's lives. Well, elaborate on that.
Yeah, we just watched a testimonial together a few minutes ago. A patient that, is a little overweight. Well, and its BMI is 42, and our society is telling us not to do surgery if your BMI above.
Because he's obese.
Because it's obese, you have to go through more tissue. You will cause so much damage that in the long run, the risk versus benefit is actually not in patient's favor. But that patient has gone 30 years. He says it.
He's in pain for 30 years.
For 30 years. And in the last 3 years, he's in such a pain. He's thinking about ending his life. He's a good man. He's a provider.
That's what he said on the video.
That's what he says.
He said he was told, if you do a fusion surgery, I'm paraphrasing him slightly, they told him, you're going to die.
That's what they are told. And we spine surgeon, we go through the training. One of the most important things we do, we manage risk versus benefit. We find out how much our procedure is going to help you, what are the risks associated with that, and when is that threshold that it's really not worth to do it for you.
So let me get this straight. If there's 1 million spine surgeries, 500,000 fusions a year, there's probably another 3 million that were turned away. Nothing we can do. Too risky. Because if you're a surgeon, and there's a huge chance there could be major complications, a surgeon doesn't want to touch that patient, right?
I'm the person who get those patients. I'm the person that those patients go after. They are told no by 5 other surgeons that,
too risky.
Too risky. You're too old. You're too big. You have other medical problems, and surgery will kill you. That is when they come to me.
Let's go to that clip. This guy on the bed just had the procedure. couple of days ago, I guess, right?
Just,
you just sent
the
him
day
home a couple of
before.
days ago.
I did the surgery 2 days ago, and patient went home yesterday.
Let's go to that clip.
You were smiling a minute ago.
Yeah.
How do you feel?
I feel real good.
Now, the surgery was just yesterday. You got one of the biggest surgery anybody can get in the spine.
Yeah.
And we fused multiple of your discs. You had a scoliosis. And tell me, how were you before the surgery? How long has it been going on?
Well, I've had back problems for 30 years. I've had 3 different minor surgeries plus a spine stimulator, and nothing helped.
Yeah.
I actually thought about suicide. You know, that's not an option. I have people dependent on me.
The pain you had in your legs before the surgery, how is it now?
Good.
It's gone?
I can't feel it right now.
Have you already walked?
Yes, I don't feel it unless I move.
Okay.
And it's minimal. It's
Yeah.
just those minor surgeries I had.
And
It's no comparison.
now, how do you feel?
Good.
Okay.
Spirits are up.
Excellent. Excellent.
So that's typical.
Well, what's typical about that is they go over a journey. They are sent around. They are told that, you don't need the surgery because surgery is too big for you, or you are too big
But
for
he was
the
30
surgery.
years in pain, about.
Yes.
He missed out. Look, I don't know how old he is. Let's say in the 60s.
Yes, he's in his 60s.
So from like in his 45, he missed out on a lot of good years being in pain.
He lost a lot of quality years that he could have put to good use for himself, for his family, for society. Because at the end of the day, we are less productive if we are in pain for ourselves, for our family, and for our environment.
Pain patients in medicine sometimes aren't even taken that seriously, right?
No, and in a way, we sort of in medical industry, we produce this kind of patient that they go through this path, and because the solution for them is too big for our expertise level, we just dismiss them, and then the narcotic epidemic is our own doing on the medical care side, because we know that what the problem is, but we are just considering it just too big for the patient to have.
You say that there are well-intentioned spine surgeons that because they're doing it the old-fashioned, open way, cutting all those muscles, that they are ruining the lives of these patients. You believe that?
Well,
because they're not knowingly doing it.
No.
But you think it ruins people's lives to get a traditional spine surgery.
Randy,
How could you
I
say
could
that?
speak hours about that, and this is a very complex topic.
Discussion,
These people, these surgeons are well-trained, good-intentioned people. They dedicate their lives to take care of these patients, but they come back to the point that, first of all, this risk of the surgery are too high. So I'm going to wait 4 years before even I touch you. By the time I start even considering surgery is the last resort for a good reason, and higher the risk of the surgery is, longer I'm going to wait before I put you through that surgery. And what that means for that patient, their marriage breaks down, their lives are destroyed, they lose their job because they cannot show up to work. So
what do you mean marriage is destroyed?
Well, I get often patients where the wife comes and tells me, either you fix him or you take him home. I don't want him.
Because nobody wants to be around a miserable person.
And these people are miserable often.
That's too bad.
Yeah, and these people, they lose their job, they lose their relationships, they get into alcohol and drugs because it is hard to be in pain. These are good people. Very many of them, they have a professional life, and then once they are at the end of the rope, if they are lucky, we are willing to give them the last resort, which is the open old-fashioned surgery.
But the longer you put it off, because you're on all these medications, you have no activity in your life. You're a couch potato.
You're deconditioned. That's the word.
Deconditioned.
Yes.
And so by the time they get to you, is your thing like, I wish I could meet them 10 years earlier?
Yes.
Really?
I wish I would have met them 10 years earlier, have put them through our process, which is not only surgery.
Okay.
We have extensive multidisciplinary path to put them through, but we can figure out these days who's going to benefit from that? And then they don't need surgery. As a matter of fact, most of our patients, we send for other treatment beyond surgery. But once it's clear that the other things are not going to help them and they need a surgery, we put them through that process before the condition, the heart and lung, they run down, and we give them years of life back that they can spend for better things.
Now, in the OR, you tell a story that you told it to me a few minutes ago, that there was an anesthesiologist who is involved in these 6-7 hour surgeries, the traditional open fusion surgery. He saw your surgery. What did he say?
Well, this was a place that
You said, I'm closing.
Yeah. This was a place that, I just started in the university. I started doing this surgery. And it was a 2-level fusion. And 45 minutes into the surgery, I'm telling, as I should, that to prepare the team for what coming next, that we are closing.
Closing means you're going to...
Meaning that we are done with the major part of the surgery. We are going to close the stitch, close the skin, and then prepare the patient to be waken up. And in that moment, the head of the anesthesiologist came above that wall that we have between the surgery and the anesthesiology, and he's looking me in the eyes and say, "Are you joking?" And I said, "No, I am. We are closing," and this is something that they're just not used to with their open old-fashioned surgery. And again, this is not it has nothing to do with the specific surgeon. It's about different mode of surgery, like
the technique's different.
Yeah.
You told me on the couch, it's very interesting. You go, Randy, I don't want to make this about me, the Abbasi method, and sure, you've done more than just about anybody else. You're faster than anybody else, more efficient than anybody else. But you made it clear, this is not about me.
Yeah.
I just want people, and I'm paraphrasing slightly, but you want people to know their options, that there's a better way. But more importantly, you want other surgeons to look at this closer.
They have to. This is unethical from us, knowing that we can do better for our patient and not to do it.
I asked you to come down to my studio today, and you said, it was interesting what you said. You said, Randy, it would be unethical for me not to do this interview.
Yeah.
What do you mean by that?
See, one of my mentors told me, do for your patient what you like to be done to your family. If my child has a problem and there is a procedure that could help my child better, safer, faster, and give me back my child, and the surgeon had a way of, one surgeon on the planet had a way of dealing with that problem, but wouldn't pass it on to other surgeons for them to learn that, or the doctors to learn that, I would say that surgeon is great that he can do that, but he's not acting ethically because he's just keeping the knowledge for himself.
So do you feel like a moral obligation to get this word out there, to use like a platform like this to let people know?
How could I not have that moral obligation when I see patients who are thinking about ending their lives, and everybody tells them, you will die of surgery. I do a 66-minute surgery, send them home next day, and put them back on their life. How could I not have a moral obligation?
So your challenge is getting both the medical community to understand this is real and it works, and to get the patients to realize you better get a second opinion at one of these 30 guys in the country that does this procedure, that are trained with the procedure.
Soon you will, I hear you're going to interview one of these surgeons for years thought...
He did it the old way.
He
said he's a convert. He could never do it the other way.
But because he saw truly the result and he cared.
Look, everybody watching this knows somebody in pain, just like everybody now knows somebody that has COVID or had COVID. Everybody knows somebody in pain. And when you're in pain, I've been in pain, I had sciatica for about a year. You're not in the mood to watch a movie. You're not in the mood to play with your kids. You're not in the mood to you're not present because it's there, right? So I guess when that's taken away, as you say, it really is life-changing.
Yeah. And I tell my staff, one of the first things I tell them, it's painful to take care of people in pain because by proxy, you suffer with them. And now imagine that person is somebody you love, your family, your wife, your children, your parent. And people stop doing what they are doing to take care of them.
Look, you have a patent on some of these things. You say you haven't made a penny from it yet. This is like your thing.
Yeah.
Like you don't go golfing after surgery. I mean, you're like into this.
Yeah.
Right?
One of the, and yes, you see, that's, I think we talked about that the doctor who invented Dr. Stock, who had a Stock kind of vaccine. He gave it out.
The polio.
For polio, yeah.
Okay.
And he gave it out because it's same thing.
He didn't profit from that at the beginning?
No, he didn't.
Just gave it away for free?
Just gave it away.
For polio.
Right now, I'm giving my patent for free so that the word gets spread out. And I think that's more important than the next 3 months or 6 months or a year. I think it's important that we give this out to the community. I train this every surgeon who wants to get trained. I train them with no cost to them
Really?
at my expense, so they get good at it. It's more
Is this
than
going to
that.
be mainstream? Like in 10 years from now, in your opinion, the traditional, I mean, I'm sure there'll be rare cases, but the traditional open, cutting all those muscles, hundreds of muscles, it'll all be this way?
Well, let's
You
put
think
it
that's
this way,
gonna happen?
as mainstream as flying is today.
Okay.
Now, we talked about that, how would it, feel that you had to drive from here to New York every time you have to communicate and so on. This is what we do. We drive in spine, we drive. Now it's time to fly. We have the technology. We just don't have enough pilots
So
that
you
are
live
trained
with
to
like
do
a
that.
sense of urgency on getting this word out and teaching other doctors.
Because this patient said he was thinking about committing suicide. There are other patients that are telling me that they were gathering pills to end their lives.
You said they're turned into junkies, that very well-intentioned surgeons, because they're saying, well, you're obese, you're overweight,
Surgery
I'm
will
sorry,
kill you.
too risky. And then they turn them into junkies because the only way they could get out of pain is all this medication.
Yes, this like
But it
this
doesn't have to be that way,
professional.
you're saying.
It doesn't have to be. See, this patient told me that he was gathering his pills to end his life. And you asked me about this, where that urgency comes from. For every person who get to me to get fixed, probably there are 3 or 4 that never get to that point. They use those pills that they are gathering to end their lives because they just cannot live with the pain. They are told, there is no way we can help you.
89-year-old guy. I've been told, Randy, it's too dangerous to do a fusion on an 89-year-old person. I'm not going to touch it.
And it is if you have to put that patient under anesthesia for 6 hours and have a half a gallon of blood loss. It is truly
What's
a
your
deadly,
oldest patient you've done a fusion on?
94 years old.
Really?
Yes.
So you couldn't do that on the open way?
No, never,
Never.
ever. That, if you put that heart and lung, that long in prone, meaning on the chest, to intubate them and ventilate them, that can be truly a deadly procedure. But even on a 90-year-old person, if the heart and lung we check them, if they are still to a certain level functional, we still can do a 1-hour surgery. So it's all about, how much stress you put the patient.
So because you're
in the
just
surgery.
moving the muscles out of the way,
Gently
rather
dilating them.
rather than cutting them all.
Yes, these studies are out there. Every additional 30 minutes under anesthesia adds 17% to the combined risk of the surgery, meaning that if you make a 7-hour surgery, a 1-hour surgery, you have 6 hours less complication to deal with. And that all of a sudden, a surgery that's not possible becomes possible. If you make a surgery that you have half a gallon of blood loss, you make it like 100 cc or 50 cc of blood loss. A heart that can manage losing 50 cc of blood cannot manage losing a liter of blood.
On one of your testimonials, the big guy, right, little heavy set, you said he's lost a quarter of a cup of coffee the size of blood.
Yes, less than 100 cc of blood, and that 3-level fusion. That in somebody who's as young and healthy as you are, my colleagues say, what does it make a difference, 100 cc or 1000 cc? We give them blood transfusion.
Yeah,
But
okay.
many times we get those elderly patients with other problems, other medical problems. It makes a huge difference
You can't
for
stop
them.
the bleeding very well on an older person sometimes, maybe.
Not
Or
only
no?
that, but young, healthy body can manage more blood loss than an elderly body with other medical problem. Now, and the result is that what my colleagues say, that the surgery will kill you. But our surgery wouldn't kill them, because now we make the same surgery in under 1 hour with 100 cc of blood loss.
I have a personal trainer, calls himself an exercise physiologist. Says, Randy, your core is like it's like a girdle that holds you in place, right? I don't know how much truth there is to that,
There is
but
a
if you're
big-
slicing all of those muscles and doing a fusion, the spine is kind of on its own. Doesn't have anything kind of holding it together, or it's less.
God, nature, evolution build us in certain way. There is nothing in our body that isn't there for a very good function, and all those muscles there are, you're absolutely right, like a girdle, like keeping us stable, keeping us on our balance in our spine. And sometimes we have to cut those muscles, cut those bones, because they are pushing on the nerve. But once we take those structures out, that spine is never the same ever again. And again, it comes
So
back
they're walking
to that.
around without muscles supporting their spine.
That is exactly
Is
what
that
we are
right?
doing.
That's
That
why
is
when I had a
exactly
guy
what
on
we
the show that said, I refuse to fuse.
because the amount of the damage you need to do to get the job done is tremendous, truly tremendous.
Now, I have to ask you about scoliosis, and we're out of time, but it's got to be true. I mean, for severe scoliosis, you can't do it this way. Don't you have to you have to open them up for scoliosis?
Well,
True or not true?
it's more complex than that.
Okay.
Now, I would never do a scoliosis 7 years ago with this technique, because these are truly tremendously complex surgeries. But now I have done 1,300 of these surgeries.
Of scoliosis people.
Well, no, I have done 1,300 of the olive procedure. So there's not a week. This week I did 3 scoliosis surgery. Next week I'm going to do 4 more.
Takes you about an hour?
Well, this patient we just looked at, that was a scoliosis. One of them took me 66 minutes.
You're
The other
straightening out
one,
the spine?
yes. That's
Is this
what you
true?
do.
You told me this. So these people, you see these people that are hunched over. They can't stand up straight anymore. They're in their 80s. Can you fix that with this procedure?
We take care of them every week.
Really?
Our patient who have been told they cannot be helped with open old-fashioned surgery, once we do the surgery, they come back and tell me, and I have testimonials to that effect. They come and their neighbor says, you're walking straight, or they can stand up in the church and sing with the rest of the church, where they could never ever do that.
So you could straighten out a spine that's stuck forward.
Well,
most cases.
In most cases, depending on the many different factors, this is a complex kind of surgery. But
it can be done.
We do those kind of surgery every week.
Is that right?
But that requires a tremendous amount of education about being able to do that through small holes. Like everybody can, or many people can do scoliosis surgeries through a big opening. But being able to do that minimal invasively is truly a holy grail of spine surgery.
Now, just so I understand, most of the people that are leaning forward, it's because they have some sort of a stenosis. It gives them relief to move forward.
It opens,
And then eventually what, it gets stuck there?
No, it is a combination that, at first, your body holds you in a place that release the pressure on the nerve the best of your body can do. But eventually, your muscles and your bone settle down on that kind of position. And that's a vicious circle of pain, positioning so you reduce the pain, and then eventually, being fixed in that position. And that is one of the problems.
But you can straighten them out. I mean, the bottom line is,
if it goes for years, then the bone grows in the wrong situation.
So
then
you
it
can-
becomes much more difficult.
but you can do it though.
We still
can
can
straighten
do
them
it,
out.
but much harder. If they have to wait for that for years, so the bone is remodeled, we call it bone spurs and
okay.
osteophytes, it can become harder. But yes, we still can do
Kind
that.
of break up the bone.
Sometimes
free
we
it
have
up,
to, but that becomes
and you can get somebody standing up straight.
yes.
Now, look, Medicare, Medicaid, insurance covers this, right?
Yes.
So it doesn't matter how poor you are, how wealthy you are. Yeah. Do you ever see people that are hunched over? I mean, do you ever want to say something to them? I mean, your personality, do you ever approach these people?
Now, well,
it's
this
tough
is
to
a
do.
this is a tough thing to do this is what I'm here to do. What you just asked me if I'm doing that. I think I need to bring that to bigger publicum rather than just one person in a supermarket or
Okay.
because I think we are in
Good
a
point.
society that that I need to put my effort and energy to help my patient the most efficient way I can. And
Okay.
this is, I think, the most efficient way to get the message out there that the patients have a choice now.
22 years ago when I started the television show that now airs nationwide, that reversing type 2 diabetes was unheard of with just food. Now it's mainstream. The guys that were preaching nutrition as a way to take care of your type 2 diabetes were considered quacks. I asked you, are some of the guys considering you quacks? Because the doctors that are doing all these newer things, they consider them a little crazy at the beginning. Because you said you told a spine surgeon and you said, hey, tell the story. Tell that story. We got about a minute left.
Well, I'm one of those person that I don't believe in the medical society. We are pretty well educated, civilized people, and everybody who look at me and what I'm doing, they know I'm serious.
Yeah, okay.
But certainly some people, they question if my data truly are what I'm saying they are.
Your results, yes.
If they truly are, and that is a legitimate thing. I don't take that personal. But yes, and that's their job to do. You're going to meet one of those people in few weeks. You can ask him that question.
But what'd that guy tell you?
Yeah, they say
Like you told him,
one of them told me they're too busy to come and to one of my labs. And
No, but you told the story better in my green room.
Yeah.
You said, hey, instead of 6 hours or something like that, I want you to view what we're doing. I could do it in under 40 minutes, under 30 minutes. He said, I just don't have the time.
Yeah, well, this is a surgeon that needs about more than 5 hours to do the same surgery that we do in 40 minutes.
He doesn't believe it?
He doesn't believe it because I think, in a way, this is too far beyond what he considered is possible. In a way, that is a problem of being a wonder child, because what you do is beyond the grasp of people who are just mainstream. Like, if you remember, I told you, if you go back 150 years in time and tell them you go to New York from San Diego to New York in one day and come back, as well, that would be beyond the grasp.
You can't
It's
believe it.
inconceivable that surgery that he does in 5 hours, it can be done in 40 minutes.
Okay.
But I think that is now my job to just keep bringing the word out and let the patient be the talker.
You have a huge training facility, right?
Yes, we do. We have a campus.
You have a campus
Yes.
where you teach spine surgery.
At no cost to them. They just have to come and learn.
How big is it?
It is 120,000 square feet
120,000 square
with
feet.
3 buildings, and we have all the facilities needed to not only teach them, but as well, this is my true pride in this is that I made that learning experience for any surgeon who joins us more concise, more efficient. They can be as good as I am in 1/2 to 1/3 of the number of the cases they need to become this efficient.
It's interesting. You gave me the analogy. It's like certain people are like, they learn to fly, like the basic plane. Well, that's different than flying a 747.
Yes.
Then they learn, takes more skills, more training. So that 747 pilot, it's different than to flying the space shuttle.
Yes.
Much more training.
Much.
And you compared what you're doing the same way.
Yes.
It's like a different level.
And I have 2 tasks here. My job is twofold. First of all, every pilot who wants to fly a space shuttle, I'll make sure they learn it the best way they can. But as well, we made the science of the entire minimal invasive spine surgery. We took it apart. We took like an analogy of the shuttle. We took the shuttle apart and everything that could be automatized, like gear shift to automatic, we automatize that. Now more people faster can learn that. So, and that is true, that's my true hobby, to take complex tasks apart, make them easier for a surgeon to learn, and help them in that process to become really efficient at it.
Okay, so the message here, if you're going to get fusion surgery, you want to research and find out how you can do it in this minimally invasive way.
Yes.
And like my buddy said, who's highly educated, Robert, he says, Randy, there's no way he could put all the screws and all the stuff through small holes. I go, I don't know how to explain it to this guy. I said, but yeah, he's doing it. And you are, right?
And yes, we are doing it every week. We have done more than the thousands of that. And my answer to that is, come to us. We will show you. More than talking to you.
Look, I know we're going way over time here, but when you first heard about this, you were, I don't know if this is true, but were you kind of a prideful, like ego going, I'm not afraid to do big open surgeries.
Yes.
I know how to control blood loss. I know how to do that. And then you heard about a guy somewhere in another state that was doing it under 45 minutes, and you're doing 5-6 hours, and you're going, I don't believe this. So you flew out to watch him.
But that was the point, Randy. I didn't just stop, I don't believe that. I said, but if there is a truth in that, it's my duty to go and see that. I said, I don't believe it, show me.
So when you saw it for the first time, what did you do? What was your mind thinking?
I stopped my practice for 3 days. I flew to Atlanta and I saw that surgeon doing that. And literally my chin fell on the floor. I was a prideful surgeon. I'm a big shot. I can do this and that. But now look at him doing that surgery in a fraction time I do. And more importantly, I watched that patient walking out of the surgery center a few hours after the surgery. And when I saw that, I said, it's not about just the time spent under anesthesia and being efficient and fast. It's about that the outcomes are unparalleled. But when that sat in with me, I knew that's my duty to not only learn it, to get better at it. Because like anything else in life, you have to start somewhere, but you have to spend the time and the energy to get good at it.
But you also have to care. You have to care about the downtime. Look, let's take it outside. There's certain plastic surgeons, one of them I know, and they always say, he'll do nose, a facelift, tummy tuck. He'll do like so many procedures, and the downtime is horrific. And this other plastic surgeon said, the guy doesn't have compassion. I'd rather stage it, because to heal from all of those things at the same time, do they realize, are they that detached? They don't realize how much suffering this patient's going through? And it's the same thing in spine surgery, that they're doing the surgery, opening them up, cutting, I think you said 600 muscles, but they're cutting like 100 muscles at least, just so they can see it better. And because they believe that this is the only thing we can do. So that patient suffers for the next year, 2 years, and maybe forever.
And these are examples. That picture that you showed, that attorney, she was told in 2 years recovery. This is a daily occurrence. See?
Yeah, my buddy just had it done. This guy's like a walker. I mean, he's built like me. I don't even know. He never played in the NFL. I don't know why he needed fusion in the first place. But his downtime, he has paralysis on his back. But this is everywhere. I guess you hear stories like this every day.
And I put those stories up online. We have 1,000 testimonials online, because this is just one of hopefully when you interview the other surgeon, you'll hear that it is hard to believe that this is the truth. And for that reason, from day one, I started doing this surgery. Actually, I started getting patient testimonials, the true beneficiary of that.
Nice. Are you guys, is spine surgery behind like the rest of medicine? For example, Dr. Gundry, the thoracic surgeon, he said before, instead of open heart, he was going in through 3 small incisions and doing bypass surgery. And look, with hip replacements, everything else has become more minimally invasive. But still, spine surgery, you guys are still doing it in this big old-fashioned open way.
Spine surgery is about 25 to 30 years behind the curve of the minimally invasive surgery as general. And that it's actually very easy to understand. See, a minimal invasive spine surgery or minimal invasive surgery as general started with gynecology. And the reason for that is once we had the scope, we knew that we don't have to open it up. But in gynecology, there is a cavity that we can approach, and there's an opening to that cavity. Once our instrument becomes smaller, like for urology, they were the
You
next
could see
people.
inside the body for the first time.
Yes, yes, with the camera, or with the, at that time, even with the, just the optical camera, not the computer or wire camera, but truly with the optical device, that scopes, the initial scopes, they were just optical devices. But then general surgery about 25, 30 years ago took over. All of a sudden, they didn't have an opening to their belly, but now they had a device, a mechanical device that could safely penetrate the belly without poking into our important organs. So, but they still have a cavity inside, and in that cavity they could put their instruments and do their job. And now later on, the orthopedic colleagues, they took over when their device were refined enough, but they still have a cavity. In spine, there is no cavity to work with.
So it's harder to see.
Much, much harder to use the traditional endoscopy.
But if there's screws involved, you mentioned 8 screws, how the heck are you turning the screws?
Well, this is.
I mean, it's all with handheld.
And looking at the C-arms, yes, looking at the X-rays, and we shoot lots of X-rays, and those X-rays, they tell us exactly where every single of our instruments are, and in a way, that is the hugely improved the safety profile, because at every single moment we see where those instruments are. Whereas in open surgery, we have fog or blood covering our fields, and when we poke our instrument inside of the disc, we don't really see where the tip of that instrument is.
Okay.
Yeah, so actually our safety record has been extremely high because we use 2 C-arm, and at every moment we see where those instruments are.
I don't know about today, but I interviewed this guy one time, a gynecologist, and he was explaining to me the DNC procedure for women. Mm-hmm. They would go in with, like he said, like a hose that you would do abortions with, and you would scrape the area, suck everything out, and then send it to the lab, look for pathology, and then say, oh, there's some. Then they go in again blindly and just suck all the area. He said, well, the way we're doing it is we go in and we just are able to grab just the pathology or just the problem, take that to the lab, so there's less downtime for the patient. But he says it takes you so much, it took me a long time to learn to do this, to stitch and everything through, from a camera. And so he says, but if you care about patients,
that's your duty to do that.
It's your duty to do it. So to spine surgeons watching this, they need to learn the better way.
Well,
but they have to leave their practice. They got to spend a lot of money. It costs them money to leave their practice.
No. Well, there's a cost of leaving your practice. Definitely, that's
but you don't get paid anymore for learning how to help patients better.
Well, but one of our surgeons who learned this from us, I had a conversation with his wife, and the wife told me, I cannot thank you enough. He's back home early afternoon because he's done with his surgeries. Now he can spend time with us.
Now I remember what you said about that. The orthopedic surgeon says, I have no time. Well, of course you have no time to learn a new skill. You're in surgery for 6 hours a day.
Where you could have spent only 1 hour to do that surgery in a better way.
I interrupted you, but go ahead.
Yeah,
what were you going to say?
Well, actually the surgeon you will see as well is another surgeon who came to me and told me once, Hamid, I cannot thank you enough. It is 3:30 and I'm done with my surgery. I would be in the surgery still until 8 or 9. And the wife of another surgeon we trained, actually, we had a dinner together, and she told me that she's very thankful now he's back home early afternoon and can spend more time with them. So it is an initial investment. It's the initial dedicating your time to learning new things, but that is how learning is. That is the nature of human. We learn things that will help us. We invest in our future, but it is nevertheless an investment that you have to stop what you are doing. You have to learn it a new way, and you have to learn and get better at that. But the rewards are very clearly within a year are there for you as a surgeon.
Good. There's no crystal ball to know the impact you had on these people's lives. Mm-hmm. And maybe someday in an afterlife, you get to see all these people saying, this is where my life was going and this is where I ended up. Anyway, I want to thank you for coming on the show.
Well, such a
Interesting
pleasure
things.
to be here.
I want to let people know that this is a 30-minute interview, but we went long. So if you go to our website at wellnesshour.com or his website, probably better to go to his website, you could see the long version of this. This is a big topic. Also on the Randy Alvarez podcast, I've got an hour and 20-minute interview with you. But this, to me, for some reason, it's a big deal because it is kind of breaking news that we have today.
Well, it was such a pleasure to be here. And I tell to everybody I talk to, this should be personal because it is personal. By the time you're 70 years old, it's almost impossible not to have spine problem. And you just have to look into your neighbors, families, parents to see somebody who's suffering with the spine problem. So it is personal in a way.
Do you live with a sense of frustration, like that everybody isn't jumping at this?
I live with the sense of that I'm achieving something of importance, and all important things are worth to go through the struggle. If you don't have to struggle for it, maybe it's not that important.
Good. I want to thank you for coming on the show. Good stuff.
Thank you very much for
Thank you,
having
Dr.
me.
Abbasi. You've been watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez for now. I wish you could help.
Thanks for watching the Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.